Hello, and welcome to the next session of the Ovarian Cancer Online Symposium. I'm Dr. Kathleen Moore, Associate Director of GOG Partners and a gynecologic oncologist from the Stevenson Cancer Center in Oklahoma City. I'm thrilled to be joined today by my colleague and friend, Dr. David O'Malley, for today's discussion on platinum-sensitive and platinum-resistant recurrent ovarian cancer. Dr. O'Malley, why don't you introduce yourself?
Thank you, Katie. Dave O'Malley from The Ohio State University, where I lead the Division of Gynecological Oncology. And in GOG Foundation, I help with the ovarian cancer portfolio as clinical trial advisor. The Ovarian Cancer Online Symposium series has been developed through a partnership between the Clarity Foundation and the GOG Foundation to provide patients, caregivers, and other advocates with impactful information and support that is personalized for their ovarian cancer journey. During today's discussion, Dr. Moore and I are going to use case studies to help walk you through and understand the current available treatment options for platinum-sensitive and platinum-resistant recurrent ovarian cancers. Dr. Moore.
Great. So let's get started. We're going to kind of use some slides just as visual aids for this discussion today. So we're just going to start with some cases that we kind of made up to frame the discussion. We'll start with a patient of mine, 67 currently. She was diagnosed, though, back in 2018 with advanced stage high-grade serous ovarian cancer. She had a primary cytoreductive surgery, which means surgery was done first, and she had a very successful surgery with no evidence of disease at the end of that surgery. She was then treated with very much the standard of care, paclitaxel and carboplatin chemotherapy with bevacizumab, and our listeners may know that as Avastin, but we'll call it bevacizumab to be compliant, and then followed by 15 cycles or about a year of bevacizumab maintenance after that. And she was without evidence of disease at the conclusion of that treatment in 2019, October of 19, was doing really well until kind of relatively recently and came in with a little bit of symptoms and her CA-125 had jumped from very normal 6 months before to now 457 that you can see. She's a very healthy individual, no relevant kind of medical or personal history, and so this looks like recurrent disease. So Dr. O'Malley, she's sitting in front of you, has been doing great, really seeing my advanced practice providers for a few years because she's just been in maintenance, doing great, living her life. Now it looks like she's recurred. What's your sort of initial workup plan for her? Would you order any other molecular testing? Like, what are you thinking about for her?
Well, first thing that jumps out is how our world has changed in 5 years, right? So she didn't have molecular testing. Now every patient gets somatic and germline testing. You could argue somatic and then triage into germline, but really every single patient. So in this scenario, I'm checking germline and somatic. Am I going to send an HRD test off? Maybe, but I'm definitely going to get full next generation sequencing because this patient's now recurred. She's in the primary setting. I would have done germline and HRD, and then upon recurrence, next generation sequencing. And this is a beautiful slide to show about 1/2 of our patients will be HRD positive, but another half, just less than half, will be HRD test negative, here referred to as HR proficient. So the molecular testing in the upfront setting is so important, but in the recurrent setting, though important, the clinical features. So this lady is 4 years out. She's almost like a new diagnosis. So I'm going to talk to her about surgery. I'm going to talk to her about molecular testing. I'm going to talk to her about PARP inhibitors and BEV and retreatment with BEV, all of those things. How about you? I mean, was this a patient you would have surgery on, or is what would you do for her?
Yeah, I mean, I think we agree, and I did make this up a little bit. I had actually germline tested her back in 18, but I made it up. So I would, if she had not had germline testing, I definitely would send germline testing, which, just to define for our listeners, that is testing for mutations that you're born with that predispose you to developing breast and ovarian cancer, and actually prostate in men and pancreatic cancer in both genders. That's what germline means. And so that has implications for family members. So it's really critically important that we test that, not just for the patient, but also to identify, hopefully, unaffected family members so we can prevent cancers moving forward. And then you mentioned somatic testing is what that means is we test the tumor to see if it has BRCA or other mutations. And I'll bump back to this slide. There's other mutations that we look for, particularly RAD51C, that have no implication for family if we find them in the tumor and not in your blood or saliva, but they do have implications for how well patients do with PARP. And then we test for this thing called HRD, which you alluded to, which is homologous recombination deficiency. And basically what that means is it's a marker of a tumor that struggles to fix its DNA. And so if you challenge it with a drug that targets its DNA, it dies, or is more likely to die. And so that's why we look for that. So I would actually send germline first, and if the germline is negative, then I would send tumor, and we'll talk about this a little bit more. There's a lot of other things we look for in those tumor tests that may help for clinical trials. So that's how I would test her. And that really is the current set of recommendations. I'm just showing you the European recommendations, but they are the same in the United States, where we really want germline first. And if that's negative, then we move on to tumor testing as a standard of care. So catching people up who kind of were diagnosed before all this came into play is an important part of our job now, so we can best assess them when they progress. Now, you asked a good question, is would I consider a surgery? And that's called secondary cytoreduction. And the short answer is, as you'll see in the case, yes, I would consider surgery. It is controversial, though. Patients always ask when they recur, I mean, almost every time, can't you operate? Please operate, please take it out. Does that make sense? And the short answer is that it's not clear. Why don't you take us through, Dr. Malley, kind of this is an area we call clinical equipoise, where you can argue it both ways, like you should do it or you shouldn't do it. So it's not an easy assessment.
So the first thing I look at when talking about secondary cytoreduction is, am I going to be able to get all of the disease I can see or feel at the time of secondary cytoreduction? Meaning, leave that we can't see or feel anything in throughout the entire body. Okay, so that's one of the number one criteria, even to consider. If I don't think that we can get her down to what we call an R0 resection, which means remove all clinically evidenced disease, then that's not even a consideration. The other, though the data is not as strong, is the time or their platinum-free interval or time from diagnosis. This patient had 4 years from her platinum-free interval, which means 4.5 years, really almost, that since her diagnosis. So you're starting to get in that 5-year window. It's almost like a new diagnosis, and we can't quite say that, but that's another consideration. What else? And we'll get into this a little bit later in the discussion, but can I remove was at the primary surgery, was all the disease removed? And did they not require neoadjuvant? We'll talk a little bit more about that. But you see here on these curves, and we're not going to go into the details, but GOG 213 was the US trial. And everybody in that trial received, not everybody, but patients received BEV. And so we looked at surgery versus no surgery, actually amazingly so, those that did not have surgery did better. But the AGO desktop, which is one of our European colleagues or German colleagues, they showed that there was a survival advantage. And then we have the SOC1, which showed there was no difference, but a slight trend towards improvement. So this question across the world is not answered. If we're looking at, is this an option? I think really where this is shared decision comes up, but those 3 criteria, and there's some others that we'll talk about, clearly need to be considered. And you potentially would do harm to a patient by delaying chemotherapy if you took them to the operating room and you didn't think you could remove all the disease. Now, sometimes you think you can and you can't, and that happens, and we're willing to take that chance. But you see here, and this is Dr. Coleman, our good friend, overlaid all the survival curves, and you can see that those that had a BEV and no surgery really did the best. And so it really is, again, shared decision, and are you going to be able to get all the disease out, but also looking back, how are they treated in the first line and how did the surgery go in the first line? You made the decision to do surgery here. Again, 4 years out, you got all the disease out, which we see here. The goal, no residual disease. And now she has a complete response. CR means complete response. No clinical evidence of disease or no evidence of disease, with utilizing the chemotherapy for the BEV. So, we talked about surgery. Now, I'm really curious to see what was the doublet you used. We have 3 doublets we can use here. So how did you treat her?
Yeah, so I did operate, it's just as you say, it's so much shared decision-making and making sure patients understand, but also patient selection is really key, like really going into the surgery with a pretty firm belief that you're going to get it all out, starting with laparoscopy, not opening somebody if you're not going to get it all out. Because you do, I think even though the data you talked about, Dave, is, while the results were a little bit controversial in terms of benefit, they were very consistent in harm. In all the cases where patients received surgery that was incomplete, they all were harmed over the patients who didn't get surgery. So doing a surgery and not getting it all out harms patients as compared to no surgery. So that's very clear, and I believe that. The question is, if you get it all out, does it help? I think there's some equipoise there. But I operated on her, we got it all out, and then the question is, right, because that's not enough. You still gotta get chemo again. I'm sorry to tell you all. And then maintenance is really important. Like, I really don't plan just for 6 cycles and stop. It's 6 cycles, and then I'm going to try and maintain the benefit we achieved. So there's 2 questions here. What am I going to use, and what maintenance am I going to use? And this is complicated because it's really based on so many things. The baseline of which is, what did the patient already receive? Well, of course, they received paclitaxel and carboplatin, but did they get bevacizumab? Did they already get a PARP? Did they get both? Because that's a thing now in frontline. And then what would I use? How does that impact what I'm going to use in the first recurrent setting? If they had a prior PARP but not bevacizumab, I would use bevacizumab. If they had prior bev, as this patient did, and not a PARP, I would use a PARP. If they had both, well, there's data for repeat, and we'll talk about that. But this is really where clinical trials become important. So these are the 3 kind of backbones that we use, and they're all based on carboplatin, because that's our key drug until it stops working. We use carboplatin. So carboplatin and gemcitabine, carboplatin and paclitaxel, or carboplatin and what we call pegylated liposomal doxorubicin, which you probably have heard as Doxil. Those are the 3 backbones to which you can add bevacizumab and bevacizumab maintenance. And these are just the studies that really gave us those as standards of care, and the improvement in time to recurrence, and then more importantly, the improvement in overall survival. And so you can see a little bit of a bump in overall survival when we use paclitaxel, carboplatin, bevacizumab over paclitaxel and carboplatin alone, as well as a little bump in overall survival when we use carboplatin Doxil bevacizumab versus carboplatin gemcitabine bevacizumab. And so because of that, I tend to use carboplatin and Doxil with bevacizumab when patients have not had it, or even if they have, and we'll talk about this in a little bit, there is data that you can reuse bevacizumab, and some countries you can't do that. In the US we can. So even if she has had bevacizumab, I might consider it. The other option is to not use bevacizumab with the chemo, just give chemo especially in this patient who had a surgery, I'm not trying to shrink any of her tumor. I'm just trying to get rid of whatever microscopic disease is left, and then transition to a PARP inhibitor for maintenance post. And this is all of the data for the studies of olaparib and niraparib and rucaparib in this setting, all of which show an improvement in the time to next recurrence, because unfortunately it will come back, but more importantly, also an improvement in overall survival with use of PARP inhibitors in patients with BRCA, particularly, actually only, is where you see the overall survival advantage. And that patient is, as I think we forgot to point out, we did molecularly test her, and she has germline BRCA. And so for her, even though I could reuse bevacizumab, all the things I told you, because of this overall survival advantage with PARP, for me, it's sort of a no-brainer that she would have gotten PARP for maintenance. I don't know what you want, if you have something to add to that.
You made this very easy for me, right? She's germline BRCA or somatic BRCA. In that scenario, if they have not received PARP, absolutely 100%. I don't believe there's any debate. I have to be honest. There's no debate. If they haven't received a PARP and they're platinum sensitive, you have to have a PARP. I do think there's a debate in the FDA has said this. They've reduced the indications or eliminated the indications for rucaparib and niraparib in non-BRCA patients. We continue to have indication in olaparib for non-BRCA patients of platinum sensitive. So we just published a paper from the Aerial 3, which is the rucaparib data, and looking at predictors of extreme responders, in this case, in a good way, right? People who had years of disease control in the platinum sensitive space. And what we found was the clinical features. What do I mean by clinical features? So did the patient get a complete response to their platinum-based therapy? Did they have normalization of CA-125? Did they have no disease on CAT scan? Those three things really predicted, as well as that HRD testing that we did. Now, the best by far is BRCA or RAD51C or D. So if you have one of those mutations or your tumor has one of those mutations, hands down, you need a PARP if you haven't had one, okay? But those other patients, if they have a complete response and they haven't had a PARP before, I'm really having a conversation about utilizing PARP in that scenario. So this case, you made it easy for me. Thank you, Dr. Moore. I appreciate that. We're going to give her a platinum doublet. We could debate that all day. There's 3 platinum doublets. I do. There's a lot more platinum Gemzar. I've kind of modified the schedule, which we've published a couple of papers from here on. But the maintenance with a PARP inhibitor, absolutely.
Let's move on to our next case. So this is a different patient. She's 55 now. She has a history of stage 4 high-grade endometrioid ovarian cancer, and that was diagnosed in 2020, so right when COVID was starting. She got neoadjuvant chemotherapy, paclitaxel and carboplatin for 3 cycles, and then went to surgery. And she had a very good response and a very nice surgery to no gross residual, and they got 3 more cycles of paclitaxel and carboplatin. She is BRCA wild type. She did have germline testing, but she responded really well to chemo, and so went on to receive maintenance with niraparib, which was for a planned 3 years. That's what the indication for niraparib is. And she tolerated this really well. She did need a dose reduction because of platelets, as many do, but was tolerating it fine. But at about 2.5 years in, the CA-125 starts to go up. And so we get a CT scan, which shows peritoneal metastases. She had some lymph nodes in the chest that were kind of, suspicious, but not measurable, but kind of clearly her disease was more active. And again, this is someone that's germline wild type. So this is another kind of question. She's otherwise healthy and she's young, 55. So is this someone you would consider a second surgery on, Dr. O'Malley? And how do you think about her?
Yeah, I think in this scenario, you really touched on a couple of really important points. Number one is what's going on today. She has disease outside of the abdominal cavity, so you're not going to be able to get rid of all of that. She had peritoneal disease, which you have to, again, make sure you alluded to putting a laparoscope in, making sure that you could get that you can completely resect her. What else is in this? The AGO model, which is actually, the model I really utilize, which is at the time of their primary surgery, they did not have any disease left at their primary surgery. What else? If they had neoadjuvant, they weren't eligible. If they present with ascites at the current time, they would not be eligible. So I think as you look at these group of patients, really seen in the past how they presented will modify if you offer them surgery. In this case, again, you made it easy for me, right? Which is she's disease in her chest, and I'm not going to be able to get all of it out. We talked about the harm we're doing. So I would not pursue surgery, even this young, healthy patient, because you're going to delay chemotherapy and clearly not benefit the patient. And as you alluded to, potentially even harm the patient if you take her to the operating room.
And I will just say, I know a lot of patients and family members are listening. This is really there's several hard discussions we have as oncologists, but this is one of the harder ones because I just can tell you almost every patient in this setting, in the recurrent setting, wants me to operate again and take it out. And that's really an understandable sort of desire. But we do have pretty good prospective data that if we are going to consider that, there are real patient selection criteria, and Dr. O'Malley just went through them, that have to be met to even consider that. Otherwise, you are almost guaranteeing harm in the way of a shortened lifespan. And so it's a hard discussion to have, but it's really important to emphasize that the decisions that we make are often based on data, and it can be frustrating, but science is important, and that's why we do trials. So I agree, I would not operate here, and I did not operate here. How about, she did get BRCA testing at the time. Sometimes you do neoadjuvant, you don't have enough tissue to send for all the molecular testing you'd want to do. And if they had a really good response at surgery, sometimes it's hard to send. So she hasn't had somatic testing, tumor testing. Is there anything else you would want to send now at the time of recurrence, Dr. O'Malley, and why would you be sending that?
Yeah, I think you and I we do a lot of clinical trials with two of the biggest institutions in the country for clinical trials for GYN cancers, right? And we're always looking for opportunities to help our patients to target mutations in the tumor with our new agents that can help kill those cancer cells, right? So what do? I said that everybody gets tumor testing at the when they're diagnosed, when we can. You alluded to potentially some challenges, and I test just something called HRD. I also said next generation sequencing. What do I mean by that? We're doing the same testing we do on the genes we do on the tumor, and we're looking at mutations which are potentially actionable. What do I mean? We have drugs which can target those mutations on clinical trial, sometimes off clinical trial. There's rare mutations, NTRK infusion. I'm still looking for one. My partner just found one, not an ovarian cancer, but we just found one. So, there are mutations that have very high response rates, which there are drugs that we can target both on clinical trial and off clinical trial.
Yeah, I agree. And we're going to show some examples of the testing that you and I both send the same assay, just to look at, kind of show the audience how we think about finding these. Sometimes you're looking for a needle in the haystack, but when you find it, it's meaningful for that patient. And so we do look.
And let me just interject there before we go on this. Needle in a haystack, You say, well, that's only 1 to 2% of the time. But if you have 4 or 5, 1 to 2% of the time, now you're at 5 to 10% of the time, right? So I think when we're looking at these, it's a number of needles in a haystack, which add up to probably, with BRCA somatic testing, which we 10 to 15% of patients, you're looking at as many as a quarter of a patient's, maybe even a third, which will be actionable mutations if you send this type of testing on the tumor.
So it is meaningful to send. We'll talk a little bit more about her. We've sent the testing. It's going to take a number of weeks to come back. You got to get her going. So kind of same question as before, what would be your chemotherapy? How are you going to think about her chemotherapy backbone? And are you going to use bevacizumab for this patient?
Yeah, so this is the data really looking at bevacizumab, which unbelievably is consistent with changes, improvements in the progression-free survival at 3 to 4 months if you add Bev in platinum-sensitive disease. Now, the only trial that showed survival advantage was the GOG 213. We alluded to that earlier, which was utilizing Bev in US-like population. So in those patients, this patient who hasn't had Bev before, who has disease outside her abdominal cavity, again, very straightforward in my mind. I'm going to try to utilize Bev if she doesn't have a contraindication to it. What are the contraindications? A lot of disease on the bowel, uncontrolled hypertension. There are some other relative contraindications with regards to vascular disease and cardiac. But those contraindications, if she doesn't have one present, I'm really going to try to get Bev to increase the progression-free survival, potentially impacting her overall survival. I mean, how about you? Are you going to add Bev to her?
Yeah, I'm definitely going to add Bev. Well, I would be thinking about it. We'll talk about her CT findings, but I would definitely be wanting to add bevacizumab here. And I think I said before, in the first recurrent setting, I do tend to favor carboplatin and Doxil with or without bevacizumab. But, my expectation for this patient and every patient until proven otherwise is that what I'm going to do is going to work, and that when they do recur again, they'll still be sensitive to platinum. So I'm going to come back to Carbogem at some point, and I may come back to Carbotaxol at some point, or carboplatin alone. We use carboplatin until carboplatin stops working, or what can happen is that your body develops an allergy to the carboplatin, which is really frustrating. And then we have to be a little bit more creative about how we treat the cancer that's still sensitive to platinum. So it's not one of these and we're done. Like a lot of times patients will see several of these doublets across their trajectory as we're really kind of quilting together these increasingly long periods of time between recurrences that cumulatively is keeping our patients alive longer on treatment a lot of the time, which I would prefer we could cure, but we are doing better in terms of lengthening that time of survival. But this patient, we talked about secondary cytoreduction is not indicated because she did not meet the AGO criteria. She does have, as we said, peritoneal metastases, but when you review the CT scan, it's like all up, kind of just tracking up the rectosigmoid, thickened, looks a little inflamed. You're worried maybe that there's some invasion there. And so bevacizumab is kind of contraindicated for her. And so gave her carboplatin and Doxil alone for 6 cycles. And she had a partial response, a pretty good partial response, but it didn't all go away. And I do get her molecular testing back during this because you have to start the chemo before you have the testing back a lot of the time. And she, as we knew, is BRCA wild type. She doesn't have a somatic BRCA. But she is homologous recombination deficiency test positive. And I'll remind you, she's already had niraparib in the front line for about 2.5 years of maintenance. So Dr. O'Malley, we're 6 cycles. What's your maintenance plan for her?
Yeah, this is a tough one, right? Because she's progressed on a PARP inhibitor before. So in the OREO trial, which you have up here, this was retreatment with PARP when they previously had PARP, if they had a response to platinum-based therapy. So in this scenario, I don't believe the patient would be eligible because she had progressed. So a patient who had progressed on PARP, I am not going back to a PARP unless it's part of a clinical trial, because in that scenario, we're adding a second drug, right? But if this patient would have stopped, say, at 2 years, even though we know the niraparib data is 3 years, she would have stopped at 2 years and then progressed 6 months later, I would have a conversation about going back to PARP with her. Absolutely have a conversation. You could argue that the PARP was keeping her disease at bay, and then when you stop the PARP, it started to grow. And you see here that the OREO data really looked at a small group of patients. I guess it wasn't that small, it was a couple hundred, but a group of patients that are wildly sensitive to platinum therapy, a group that you just referred to. So when they're wildly sensitive to platinum therapy and they haven't progressed on a prior PARP, I will have a conversation about going back to a PARP. Part of that conversation has to be AML and MDS, leukemias, right? Because we think, we don't know, we think the more exposures we have to PARP is potentially increasing our rate of secondary malignancies. So again, that's where that shared decision comes in. So in summary, if a patient's progressed on PARP, outside of a clinical trial, I'm not going back to a PARP. But if they had prior PARP and then stopped therapy, then recurred, absolutely having that conversation. And we just had some data that came out of ASCO, one of our big national meetings, showing that those patients are really different. The patient who progressed on PARP versus the patient who had previous PARP, I call those PARP exposed, and then they progress. So those two patients are very different in my mind. I mean, how would you go back to PARP on this patient who progressed?
I do consider retreatment if I don't have a clinical trial available, which we'll talk about in a moment. But I agree with kind of the theme that you brought up, that this study, this is the OREO study, was a very unique population of patients. When you make the statement about extreme platinum sensitivity, just so our listeners understand, and it's in the box here, this group of patients isn't the patient we were just talking about in my case, who's at her first recurrence. If you can see here in the upper box, you know, almost, actually over 50%, or right at 50%, had 4 or more platinums when they came onto this study, and were still responding to platinum. So platinum, 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 platinum again, responded, come on the study, or even another platinum. And so that's a very unique phenotype, and we don't often see that. And so these patients had gotten a PARP before and progressed on it. They had to stay on it for at least 6 months or at least 12 months, depending if they're a BRCA or not. But their tumors are so exquisitely sensitive to platinum that when they got a PARP again, you did see a benefit, but not much. And I think that's the thing to say. I think our audience, even if you don't know how to read a Kaplan-Meier curve, can see that the majority of patients, these are patients that have BRCA mutations, and these are the patients without BRCA mutations, that the majority, whether or not they got a PARP or placebo for maintenance, at that first CT scan, like half of them had already progressed. And so there is a small group who benefits from PARP again, and that's real. And so I do consider it, but I really think about kind of who I'm giving that to. And I probably wouldn't be someone who progressed on frontline PARP, to your point, Dr. O'Malley. But that's not who was in this study. So this study does show us we can reuse PARP, but it should be selective. I think the bottom line is we need better drugs and maintenance rather than just repeating things. Like, let's just develop some new things. But you can consider that, just like we already mentioned this, you can repeat bevacizumab as well. Now, the data actually for repeat bevacizumab is a little bit stronger than for PARP. It actually works just as well, and this was the study that proved that if patients got bevacizumab with their first chemotherapy and you gave it with their second chemotherapy, they still did just as well, and their response rates were higher. So there's probably stronger data for repeat use of bevacizumab than repeat use of PARP inhibitor. So I think I would emphasize that doesn't really apply to this patient, but just to make the point that sometimes we do reuse things and they can work pretty well.
And that's a great point, which is your difference, again, progression-free survival, very consistent, 3 to 4 months. And this is here, again, looking at about a 10% increase in your overall response rate, with much more complete responses. And we talked about the impact that has on our decision-making, but that was a great segue into clinical trials and better ways of maintenance therapy. So if this patient would have been eligible for Bev, this is a trial that I'm leading, and it comes from a long history of combining MIRV, which you've led the trials that have will have led to the indication with MIRV, the antibody drug conjugate folate receptor alpha. And so we have a clinical trial right now. MIRV is indicated in platinum resistant. We'll talk about that in a second. So mirvetuximab, I'm sorry, I referred to as MIRV. Mirvetuximab, or the trade name for that, is Elahere. We're trying to find ways to utilize the drug earlier. And so a clinical trial is looking at patients who are on Bev for platinum-sensitive recurrence, first platinum-sensitive recurrence. And then they're randomizing patients to continue Bev, which is what we normally would do, continue Bev, give about 6 cycles of the platinum doublet, and then drop the platinum doublet, continue Bev. And now we're adding MIRV-Bev and comparing it to what we've always done, which is Bev. And so this clinical trial is up and enrolling. Very, very important to screen early on for platinum-sensitive disease to see if you're in that 35 to 40% of patients that will have high folate receptor alpha expression. So something to ask your providers: have you been screened for this trial if you have a platinum-sensitive recurrence? And if not, is there a center close that you could potentially go to if you're found to be screened, if you're found to be folate receptor alpha high?
Yeah, so just can you just reiterate a little bit, what's the biomarker and how do patients know if they have the biomarker?
Oh, great question. So folate receptor alpha is looking at, it's PS2 plus, we don't have to get into that, but it's looking at how much of the folate receptor alpha is on the cancer cells, okay? And so you can screen a couple of different ways. There are commercial vendors, the companies, which we send tissue off, and part of their normal results is to say if we have high folate receptor alpha. So we can utilize that as screening now in the protocol. It's just, but also if you're at a center that has this trial open, you can sign a consent form where that tissue is sent off to be tested to see if you're eligible, and that's paid for by the clinical trial. So there's 2 different ways you can do. You can have it tested by the commercial vendor. There's many different ones that have the folate receptor alpha, or as part of the clinical trial on the screening consent while you're on therapy for platinum sensitive to see if you're eligible to go on to the maintenance portion, which is the clinical trial.
Yeah, so I think what is important for our listeners to know is that, many of you have had testing done in the past. There's a variety of molecular tests. They have various names: Caris, Tempest, Foundation, Neogenomics. There's a bunch. But before November of last year, they did not have folate receptor alpha included on them. And so you may have had testing sent, but that wasn't known. So this is something that can be tested now, and just to know for the future, or if you are receiving chemotherapy in the platinum sensitive setting, you can request that it be sent. So it will get you access either to this trial as a maintenance or for just use of Elahere or mirvetuximab in later lines of therapy. So it's something that just gets added on. You have to kind of catch people up who were tested before last year. We're kind of catching them up now, so we know who our folate receptor alpha expressing tumors are, so we can get them the right drug at the right time. So just something to think about. We're always having to retest as new tests emerge, so we know what is on our patient's menu of options. So let's move on to the last case, which is probably our most complicated setting. And this is a patient with platinum-resistant tumor. So this is a 75-year-old patient. She has a history of stage 4 ovarian cancer. She was treated with neoadjuvant chemotherapy, got an interval surgery that was actually successful, and then got 3 more cycles of paclitaxel carboplatin, followed by niraparib, which is a PARP inhibitor, here for just a year, and then she progressed. So 12 months is her platinum-free interval. She was still considered sensitive to platinum, so got carboplatin and Doxil with bevacizumab for 3 cycles, and on her first CT scan is noted to have progression with, fortunately, no ascites or bowel obstruction, but does have disease in the chest and the mediastinum and some nodules in her abdomen. Otherwise, feeling okay and good performance status, so can be treated with what we think is best. Dr. O'Malley, this patient's been sent to you for a consult now. She has disease considered resistant to platinum. In general, how do you think about treatment options for a tumor that's considered platinum resistant?
Well, I think as we look at this, I step back, particularly when these patients come to me for second opinion, right? Which is, okay, what's her histology? Is she serous? Is she mucinous, clear cell? Is she high-grade serous or low-grade serous? So obviously the difference treatments for low-grade serous versus high-grade serous, everything we've really talked about up to this point has been serous cancers. These other rare tumors, and we'll talk about low-grade in a second, but the high-grade serous, I want to confirm. I want to go back and even have the pathology reviewed, making sure I have those what we talked about, the next generation sequencing. But a really important aspect of this is this particular patient progressed on the platinum doublet with PLD and carboplatin. But if she would have gotten a complete response and then recurred within, say, 4 or 5 months, the classic historical definitions would have been, well, she's platinum resistant. But really, platinum resistance applies to the first-line therapy. So the NCCN guidelines got updated this year, and they now utilize platinum and platinum doublets. And you see here on the screen, and we've highlighted some of the changes in the NCCN guidelines. So they are now saying, continue to utilize platinum until they have progressed on platinum, or they have a hypersensitivity, they're not, or they can't tolerate it. There's people with hematologic toxicity. What are some other options? I really go through this list, and unfortunately, they're somewhat limited outside of clinical trial. There's probably about 3 to 4 options. You see on the left side, cyclophosphamide, doxorubicin, gemcis, which is part of the platinum combination. Ifosfamide, I can't tell you the last time I used ifosfamide for ovarian cancer, but it is irinotecan, same thing. Exabethylone Bev, based on a phase 2 trial. Very interesting. Our colleagues at Yale utilized and ran this clinical trial. Really interesting data when you combine it with Bev. This is a drug that's approved in breast cancer. And some others which are listed. The most common ones we use are paclitaxel, and we've talked about PLD, topotecan. So, but these are some other recommended regimens beyond those usuals that we will utilize. Now, when I have a low grade, completely different, right? I will use some of these, but really I'm looking at other therapies. I know, Katie, this is one of your passions. How do you look at with a low grade serous cancer patient?
Yeah, so just like you said, and I see a lot of consults as well, the pathology review is just key because these can be very tricky to diagnose. But if I'm sure I have a patient presenting with a recurrent low-grade tumor, chemotherapy is still in play. Like, it's not entirely inactive, and that's important to say. It's just not as active as it is in high-grade serous. So it's still there, but we tend to go to endocrine therapies for, one of our colleagues calls it the breast cancer of the pelvis. We tend to use our breast cancer regimens with endocrine therapies, letrozole, fulvestrant, combinations with CDK4/6 inhibitors kind of routinely. And in emerging, you see it here on under targeted therapy on the right-hand side of this slide. You'll see at the very bottom, trametinib and binimetinib. These are MEK inhibitors. So these are listed on the NCCN. They are not FDA approved, but these are targeted therapies that really target tumors that have alterations in that particular pathway. And they have a reasonable response rate. It's about 15 to 20%, and they can kind of hold disease stable for a while. But they do have some toxicities that are somewhat limiting. We have to watch cardiac function very closely, and they cause rash. So one of the clinical trials that has been enrolling and is about to launch in a big phase 3 is taking the next generation of MEK inhibitors. These are it's a combination MEK-RAF inhibitor called avutometinib, avuto, which is hard to say, plus what's called a FAK inhibitor. So it's 2 drugs, but basically 3 targets that use MEK and then outsmart the mechanisms of resistance. And that has been shown, and you'll see some data at an upcoming meeting. I wish I could tell you it right now, but it's embargoed, where we actually see high response rates, which we don't ever see in low grade. We stabilize low grade tumors. So you don't see them shrinking a lot, you just see them not growing. Here we see them shrinking and not growing for a long period of time. So this is led by a company called Verastem, avutometinib and defactinib. It's about to launch its big phase 3, so keep your eyes peeled for that. If you do have a low-grade tumor, it's not without toxicities, but they do appear to be less rash, less cardiac toxicity than MEK alone, but the phase 3 will really adjudicate that. But we do think this is one of our more exciting opportunities for low grade right now. Like when you and I look at a test like this, what do you see here when you're trying to plan options for your patient, Dr. O'Malley? Like what things stand out to you as targetable?
Yeah, so I think anything targetable, you brought up a really, really good point I want to emphasize for the audience, right? Which is if you would have sent this tissue testing 6 months ago, a year ago, it would not have given you the folate receptor alpha. So if this patient recurs in platinum resistant, I need to make sure she has folate receptor alpha tested, because it wouldn't have been sent, for example, when she's platinum sensitive a year ago, which is what I said, right? So it's very important that if you haven't had that testing, that it be resent now. What am I looking for? Actionable mutations, right? Starting in the bottom right, folate receptor alpha, ERBB2, HER2/neu. We have antibody drug conjugates targeting HER2 at this point. You have the big, red arrows, CCNE amplification. We have trials, WEE1 inhibitors, ATR inhibitors, which are targeting this machinery. Obviously, BRCA, RAD51C or D. So this patient had a PARP, so it's a bit of a moot point. But we have a trial open right now targeting ARID1A mutated tumors. And what else? You can't forget about that rare but actionable NTRK infusion that I refer to. And the reason I laugh is Dr. Moore and I continue to look for these. They're unbelievably rare. But what else we see rarely is tumor mutational burden high, or MSI. So we really have these opportunities, though it's only about 1 to 2% of patients, that if you have that immune therapy has shown to work very, very well. So, it is a small chance, but as we said earlier in this conversation, a 1 to 2% chance. You have enough of those, and now you have a real opportunity. There's just so much here, Katie. We could talk all day. What else? What else do we need the audience to know about? When we look at these.
But this is just to your point. I just want our patients to sort of understand what we're we're kind of scheming in the background of what things make the most sense for you while you're on standard of care medicines for platinum resistance, or maybe another trial. So every single one of these that I'll get BRCA1. Every single one of these are like, we look at every single one of these. So some of them, this patient doesn't have. She doesn't have BRCA1 or BRCA2. So I check those off. I'm always double checking that I didn't miss something. MSI is microsatellite instability, tumor mutation burden. Those are markers for immunotherapy, which are rare. It's like 2% will have abnormalities there. This patient does not. But if they do, I want to get them an immunotherapy, even though that's not common. ARID1A, there are clinical trials for ARID1A. There are clinical trials for ATM, which she doesn't have, those two. CCNE1 amplification, does she have that? Have trials? She doesn't have that. But she does have that folate receptor alpha expression. It says negative though. So you might say, well, why are you talking about that? But she actually is 2+, 40%, which is a medium expressor. So this is something that Dr. O'Malley and I are trying to make sure our providers understand, is that it's not black and white. It's not like positive, negative. The FDA indication is for high, but we have data for medium where it works really well, which I'll show you in a moment. This is just the next page. I pulled another sheet of, oops, there we go, lost my cursor. Sorry, there we go. Failed at advanced Zoom today. Here we go. I just pulled another sheet off another, well, my circles are there. I really did fail advanced Zoom, but we'll get over it. I pulled another sheet up, just another patient, so you could see kind of the other things we're looking for. You know, there's clinical trials open for ovarian cancers that have KRAS mutations right now. This patient doesn't have one, but I'm looking. I have a checklist. Does she have a KRAS? Does she have a RAD51D? Does she have TP53? Those things all matter in terms of how we're thinking about patients and trying to making sure that they have options to access the trials that are most relevant for their tumor. It's getting very individualized, finally, which is what you want. So, so this patient, just to come back to her, Dr. O'Malley, so she's had bevacizumab and progressed on bevacizumab, and her third-line treatment, I think you alluded to, is sort of monotherapy, chemotherapy. Weekly paclitaxel is probably our most relevant option. And so when platinum's not an option, you said that bevacizumab is kind of off the table for her. But why don't you take us through sort of how you think about, in general, standard of care for platinum resistance?
We really look at, and the use of bevacizumab has really been shown to not only improve upfront in platinum sensitive, but really platinum resistant. And this is really where we see impact on symptoms control. We have not seen impact on overall survival, but we have seen impact on patients with ascites whose tumors are causing them symptoms: abdominal pain, distension, pressure. And when we have those symptoms, it is pretty clear that the utilization of bevacizumab with chemotherapy helps. And now we see that we've alluded to this weekly paclitaxel being is a higher level of response, but yet it also has the highest inconvenience, not highest, but it's inconvenient, it's weekly. Side effects: neuropathy, hair loss, neuropathy, damage to the nerves, and hair loss. So though it has one of the better response rates, it's more difficult to tolerate for multiple reasons. So, and I would argue that the MERV now is giving us the same type of response without some of those safety. Now, unfortunately, our response rates in single agent chemotherapy are modest. Really 5 to 13% are the response rate. Now, this is clinical trial response rate. So those are disease which shrinks at least 30%. we have many of these agents that the disease will be maintained or just shrink a little, but not hit that 30%. So these are underestimating the clinical benefit, but these are the response rates which we talk about in clinical research. And you see, again, modest. We're modest. I think the next slide, Dr. Moore, we have so this is really the opportunity. When we talk about clinical trials and we talk about having more options for our patients, I love this diagram. And this is really looking at the number of agents out there that are being developed in platinum-resistant ovarian cancer. And we have so many more options than what's available to us through FDA-approved agents or commonly used agents through clinical research. Katie, I know that this is one of your passions and you're involved in so many of these trials.
Well, we both are, but I think this is, it was beyond the scope of this presentation really to take you through all of the trials that are open, but really just to highlight a few that are really interesting. You know, I mentioned to you, we look at the few patients who might be eligible for immune therapy, meaning immune checkpoint inhibitors like pembrolizumab, which you know is Keytruda. They don't work very well in ovarian cancer, except in a few. But there are studies ongoing of very novel immunotherapies. This is one of them. It's called nemvaleukin, which is interleukin-2. It's run by companies called Alchemyres. They have a study, a very interesting study going with combination of a checkpoint inhibitor plus IL-2 versus chemo. And that's open and accruing right now. And it's not biomarker linked, but it's really taking a very novel strategy towards ovarian cancer that I think is exciting, and I'm excited to see kind of the results of that play out. And then we talked about mirvetuximab. We're going to show that in the next slide. That's how we're going to end this talk. That's here. This one is FDA approved now, so it actually made it into the bullseye here. But there's others out here. This is a drug called RDXD that's entering a clinical trial soon. It's another antibody drug conjugate like mirvetuximab, but it targets a different protein and it has a different chemo. So it's another targeted chemo that will open up, hopefully, eligibility for these antibody drug conjugates beyond folate receptor alpha. So we're excited about that. Are there any others on here you wanted to call out, Dr. O'Malley, that I didn't?
Well, I think, yeah, I want to talk kind of more, you know, what are, and you broke it down here from, so overall immuno-oncology, we believe this next generation of immune therapies, bispecific antibodies, the next generation of IL-2, is one group. Okay. Then we have a further agents being developed, anti-angiogenic, also these bispecific antibodies. Okay. Now then we go to the left side of it and we're trying to manipulate the cell, how the cell communicates, how the cell repairs itself. Okay. And so, the WEE1 inhibitors, Zentalis has 2 really cool trials out there. Okay. And then antibody drug conjugates. I mean, we have the world of antibody drug conjugates continues to get, the targets get better. The payload, the cytotoxic, what kills the cells, are getting better. How those are linked are getting better. And we're going to continue to develop drugs like they have in breast cancer that really targets the right drug, the right patient at the right time. I love you said that earlier. I think I added one more part to that. But that's really the 4, making sure. And you know what? We're going to take, you have the opportunity as a patient to get each one of those sections and maybe a couple within the same section, because antibody drug conjugates with different targets in different payloads are going to allow you to get more access to those agents.
Exactly. And so you can tell we're kind of the most excited about antibody drug conjugates because they work. So I am a little biased, though. And so we are just going to kind of end for this particular patient that I showed you, who I showed you the KRAS testing, and she's folate receptor alpha medium. And so she doesn't meet eligibility by the FDA approval that came from the SORAYA study, and assumed Mirasol for folate receptor alpha high. So we have to say that. However, Dr. O'Malley can tell you about his trial called Forward 2 and why this may be an option for her.
Yeah, so what we did is on that trial, we enrolled patients across all expressions, okay? They've decided to do construction right above me, so if you hear background noise, I apologize. But you know, what we've done here is we publish our experience across all folate receptor alpha expression. And we showed that the response rate was right about 40% when we combine MERV plus BEV, okay? And really consistent across all levels of folate receptor alpha expression that we hit a 40% response rate. Remember, that's the clinical trial definition of response rate. The schema on the upper right, excuse me, the diagram on the upper right, you see that almost all patients had some clinical benefit, okay? And so what the NCCN did when they listed out the guidelines for MERV-BEV, they just said folate receptor alpha expression. They didn't say high, medium, or low. They just said expression. So this has become an option for our patients, even those that don't have high expression. Now, Dr. Moore said, this is not the FDA approval. This is an off-label discussion that we're having, but it is NCCN guidelines listed. It's called a category 2B, and this is an option for patients. How low a folate receptor alpha expression is something that we would use it. Well, anything less than 25% without debate, I shouldn't say without debate, we would not use, because that would be considered essentially negative. But you know, when we're really looking at those levels, that 25 to 50, 50 to 75, and greater than 75, those are considerations that you should have a conversation. How about you? How low? My specialty pharmacist, Dr. Moore, asked me, how low is too low the other day on folate receptor alpha expression?
I mean, it's hard for me to say because, you know, I am biased because I've participated in this development of this drug for a long time. So I think our listeners should know that it is a bias of mine. And I've seen it work in low. So I feel like it should be available to people to try if they're well counseled. But I tend to use the 2+ as a general marker because we still, as you mentioned, this is NCCN listed, is not FDA approved. And so some insurances will not allow this. And so I have to emphasize that, but many will because this is published and you can show the benefit. And I do think it's worth a try, and I've been able to get it for my patients. The one thing I wanted to point out to because there's a lot of patients that are listening, and I actually draw these waterfall plots for my patients when I'm explaining response rate to them, because response rate often sounds terrible, but response rate on a clinical trial, as Dr. O'Malley alluded to, means that when we add up all of your tumors on the CT scan at the beginning of the trial, and then we add them all up again at some number of CTs later, a response rate means you've decreased by 30% or more. That's what this dotted line is showing you here. And so it is true that all of these patients who participated had a 30% reduction, and they were visceral responders. That's your 40%. But these patients here, their tumors didn't grow, and many of them shrank some. So this is clinical benefit. And this is what we care about as physicians. I mean, I care about response rate as a trialist, but as a physician in front of a patient, I care about their tumor not growing and shrinking as much as it possibly can, but I'm fine with 20% as long as it doesn't grow right back. So this is really what's missing when we talk to you guys about response rate. Response rate's below this dotted line, but this is still the patients who benefit. These patients, unfortunately, that didn't work, but there's not many of them, which is why I'm kind of pro using things. So just so you understand where the definitions come from. Any final words, Dr. O'Malley, on platinum resistant or recurrence, or what you'd want patients to know?
You know, I think making sure you're being seen at a site that has a large volume of ovarian cancer patients. Expertise within ovarian cancer is very, very important. making sure that you have access to clinical trials to the best of your ability. Some patients live in areas that they just have trouble getting access. There's a lot more resources available today than there was a few years ago with regards to supporting patients so they can participate in clinical research. And that's really how we're going to get access to these exciting drugs before they're approved. And so, is there an option for a second opinion to a site that's a high volume or to a site that has a lot of clinical trials? It's a possibility. Clarity has done a wonderful job of trying to match patients to sites that have these options for you. And we're there and we want to help you. And thank you for taking the time today. Dr. Moore, bring us home.
Thank you. Thank you for taking time to join us for this ovarian cancer online symposium. The Clarity Foundation and the GOG Foundation Incorporated would also like to thank our commercial supporters for this video series, and those supporters include Novacure, Veristem, Immunogen, Alchemers, and R-Pharm. If you have any questions or are looking for more information, please visit the Clarity Foundation website or contact the Clarity Foundation by phone or email. Thank you so much for joining us and have a great day.